All right. Can everybody hear me okay? Hi, Brynna.
Hello.
Hi. I'm just going to turn my volume up. I am so excited to have you with me today, Brynna. Welcome.
Thank you.
Cool. I know we're starting a little bit late. Better late than never, I suppose. We're hoping to start, I guess, to introduce what's happening here today. We're hoping to start a Stay in the Game live podcast series to meet our practitioner team. Today we have, as a part of our first episode, Brynna Malachny, certified athletic therapist. Yay!
Hello.
Woo! And I am Melanie Tuck, for those that don't know me. I'm the owner of Collegiate Sports Medicine, and I am so proud of our team and all that they have to offer. And I just want to be able to utilize this podcast as a way to showcase some of the ways that we can help the community and help people stay at it. So when we're looking at stay in the game, we're thinking work, life, and play, all ways to stay at it. And so today, before we get into the topic, I want Brynna to introduce herself and a little bit about, obviously, Brynna, what you do, who you are, and then we'll get into the topic.
Yeah, so like you said, I'm Brynna Malachny. I'm a certified athletic therapist here at Collegiate. Today we're actually celebrating my 2-year anniversary, so that's super exciting. As we all know, it's been kind of a crazy 2 years, kind of a weird time to start your career, but we did it. We're here. But yeah, I'm a certified athletic therapist. I was born and raised here in Red Deer, actually. I skedaddled off to Winnipeg for a couple of years to do my athletic therapy specific training, and then came back here. So I work my days in the clinic, and then evenings, the majority of the time, I'm working with hockey. I'm working with the Red Deer Optimist Chiefs right now. And then come springtime, I'll probably be working with football or lacrosse or baseball or whatever my heart fancies this summer. I'll figure something out. But yeah, really working on the sidelines with those teams, not only in those not fun situations where someone's gotten hurt in the field, but keeping them from getting hurt is always my goal. So yeah, so that's a little bit of who I am.
Awesome. Well, thank you so much for taking the time out of your schedule. I know you've been kind of back to back with clinic treatments and stuff like that. And so it's an honor to have you in a few minutes of your time. Now, I'm a certified athletic therapist as well. And so obviously, if there's clients out there that are joining us today, and you have questions for either one of us, just go ahead and pipe in, or ask your question in the comment section. We'll also have this segment saved, so you can always go in and watch it later and reach out to us through Messenger, that kind of thing. So today we're talking about pain management without the drugs. And this is kind of an odd topic, I suppose, but we'll get a lot of people that will, take Tylenol and Advil and different things that obviously has an impact on their system. And Brynna will talk about some of that today. And, to figure out ways, anything that we can really think of to employ other types of pain management, we often try to get our clients to do. And we kind of want to, I guess, explain some of the ways that other things other than medication can help. And the reason why we would want to try some of these things. A lot of people say, yeah, but if it works, why mess with it? And I think messing with it is important. So, Brynna, what types of things do you use other than obviously medication? Because we're not physicians and we can't prescribe that. To help people with pain.
Yeah, it's always interesting with the medications because obviously that's kind of the first thing that people bring up. They're like, should I take this or should I take this? And at the end of the day, as you know, that's outside of our scope. We really can't delve too deep into that. I always take it as my job as an educator to kind of tell people about what can happen with the long-term use of those, right? Of long-term effects on the stomach and the liver and things like that. So in the clinic, we try to use what kind of modalities that we have here in the clinic, but obviously people can sometimes only come in here a couple times a week, so we have to figure out ways for them to take care of themselves at home. So I mean, in the clinic we have things such as TENS, we have ultrasound, we have I don't do it, but like IMS and the dry needling, but some of the easiest, most basic forms of pain management is that heat and ice that we so love, that people are constantly asking which should I do, and that's kind of why we're here today, I guess.
Yeah, absolutely. You mentioned heat and ice. Brynna, let's circle back to those in a minute. Tens, we get a lot of people that will, just go onto the internet and buy like a Dr. Hose, or they'll stop into the clinic and they'll pick them up from the store. Obviously, the physios and athletic therapists use them in the clinic. It feels good, but how does it work? And is it okay that people just pick one up off the internet and kind of stick them on? I mean, obviously people have been doing it for years and years, so it must not be too bad. Could just chat
Yeah.
about that.
Yeah, so TENS is one of those electrical modalities. So because we're actually introducing electricity to the body, there are certain things that, like, we call them in our field, those contraindications, right? The things that say, you know what, no, you shouldn't put this on this person. I mean, overall, those machines are really safe, right? We can use them for so many different things. That's why they can sell those things over the counter without a huge fallback on that, right? Um, I don't want to go too far down the rabbit hole of the science behind this, because I know I find it fascinating, and I don't know if everybody else does, but especially with that TENS machine or the Dr. Hose machine, it does two different pain receptor channels. One we kind of refer to as that gate control theory, and one is like an opiate theory. So gate control is typically what we use more. So I always describe that to my clients of, like, we've got a whole bunch of different nerve fibers in the body. Some respond to light touch, some respond to deep stimulation, some respond only to pain. Now, the one bonus and the reason why the gate control works is that those fibers that sense pain are actually the slowest. So, bonus for us, the body can only sense one of those fibers at the same time. So, if someone is in pain, we can hook them up to this TENS machine, and what it's doing is it's stimulating those faster responding nerve fibers. They get to the spinal cord first, they say, nope, I can only deal with one signal at a time. Shut that door, that pain signal comes in, door is not open, we don't sense the pain. So, super basic form of a very scientific thing. But it is really cool. I mean, we do the same thing without even realizing it. Like, if we bonk our elbows on something, our usual response is to kind of grab at it, to rub at it a little bit. And the physiology behind that is actually saying, yeah, we feel that light touch before that pain. So we can actually shut the door and only focus on one thing at a time. So those TENS machines are great. They really do work physiologically with the body to decrease pain. But like I said, because it is electricity, we try to make sure that it is safe to use. So there are certain conditions, things like that, we'll ask clients to make sure that they don't have those before we hook up some kind of electrical thing to them, just so we're not making anything worse.
What, like a pacemaker, that kind of stuff, or what other
Yeah. So, like, pacemakers, I know one that they bring up a lot is if someone has epilepsy, we don't really know how they might respond if we're introducing electrical stimulus to the body. One of the biggest ones is that someone should be able to feel that sensation, so we know that we're not turning up the intensity too high. So some things like diabetes, circulatory problems, where they might not be able to feel that sensation totally right. Those are certain kinds of contraindications. I mean, pregnancy, if someone's got an infection, if someone's got an open wound to the area, we don't want to exacerbate those kinds of symptoms. But overall, it's a pretty safe modality.
Okay. So is there like a duration that you recommend for people to put it on for, or is there too much of a good thing, such a thing?
Right? Like, so the literature behind it is a little bit gray on that side of it. Depending on the study you read, some of them say you can use it as much as you want throughout a day. They don't recommend more than like 30 to 45 minutes at a time. But they're saying that you could really use it as many times in that time frame throughout a day. Some studies say 4 times a day. At the end of the day, you can do what you want as management, but at the same time, if you're just kind of covering up that pain and there's a reason behind it and there's a cause that we can also address, that's obviously important as well. But yeah, usually I tell my clients, about 30 to 45 minutes, no longer than that. And then I usually recommend that no more than 4 times a day kind of thing. You don't want to be living hooked up to this machine.
Right. So if you have low back pain and you're driving to Calgary kind of thing, put it on for half the trip sort of thing. And a lot of them have like little timers and stuff like that, I think, that will make them shut off. So, I think just to kind of interject, if a person's going to sleep with it, you can have them shut off so that you don't leave it on too long, right? Like, I don't think I've seen one without a timer.
No, most of them have a timer, but I'll even tell my clients just to be safe, like if you think that you might fall asleep, set a timer on your phone or something. Like I do the same with any modality. Like if you're going to lay down on heat, if you're going to lay down on ice, like set that timer just in case, because you don't want to fall asleep. And especially with ice and heat, that can not be a great situation. But same with that TENS machine. Just in case it doesn't have an automatic shut off, you don't want to be sleeping with that on.
Right. Now, Brynna, I know that, a lot of people say, well, what's the difference? What can Tylenol, do really that's going to hurt me? And, do you have ongoing use of anti-inflammatories, ibuprofen, or the hard, more prescription-based, either opioids or non-steroidal anti-inflammatory drugs? Do you have a kind of a short list of things that a negative impact can have on people?
Yeah, I mean, those can affect not only like everything in your body has to be processed by those kidneys, liver, stomach. It's going through. It's going to have effects on all those systems. Obviously, short-term use, less problems. But if someone's using something longer lasting than that, it's going to have effects on those. Certain opioids or pain meds can have effects on your mood, your sleep, your overall like state of being, your overall mental health. So those we try to avoid, specifically with those NSAIDs, as we call them, those like non-steroidal anti-inflammatory drugs. Charting NSAID is just significantly easier. But those actually inhibit what we call those prostaglandins in the stomach, which create that protective lining. Well, if you inhibit those, that's when you hear about people getting stomach ulcers, things like that. So those have not great avoid that and use something that's not actually introduced orally into the body, then why not, right?
Right. And I think prostaglandin inhibition as well can change and affect healthy collagen formation. And so often if people are on long-standing anti-inflammatory use, we're looking for healthy collagen reformation as a person's healing from a tendon or ligament injury. So it can impact the healthy recovery of that tissue proper, like the tissue that's trying to restore. And so, it is definitely something to talk to your doctor about as well. And these little TENS machines, a person can get them prescribed by their doctor and have them covered under their health insurance if you have health insurance plans. And I think from an administrative perspective, a lot of times we forget about that as a practitioner, that it is actually something that can be a prescription. They're only a couple $100 at the absolute most, and they last for years and years. So, I think it's certainly a good option to consider. So that's cool. Yay, Karina saying happy.
Thanks, Karina.
We got our first comment. Woo! If anybody has any questions, please shoot them into the comment section, and we'd love to answer them on the fly here. So, Brynna, you mentioned heat and ice. Let's chat about heat a little bit. So, besides pain management, and obviously it sounds like the gate mechanism, so that's kind of where, I'll just try to summarize what you said. So basically where pain is traveling on a slower kind of conducting neuron, and if you can override it with a touch response, then it closes the gate to the pain message coming through. So it feels better, right? It's you said bump your elbow, you grab it, and it actually makes it feel better. So the touch kind of component is used for that. So how does heat work, or does it, or what? And what else is it for?
Other than just feeling kind of nice overall, especially when we're getting this colder weather, it's always nice to be warm. But yeah, heat actually does follow that gate control theory as well, right? So those same neurons that sense that light touch also sense temperature changes as well. So same thing, you can combine heat and TENS. I am careful with clients when we talk about that, because obviously that heat is also going to override those pain signals as well, but also it's going to minimize the sensation of the TENS units, right? And for anybody who's hooked themselves up to one of those, you do know, I mean, if you crank it up too high, you're going to put the muscle into spasm, which is that funny in some situations? It is what it is, but you can minimize that sensation that you're getting when you put the heat on. So I always tell clients if they're putting the TENS on with the heat, set the intensity first, find a comfortable spot, put the heat on, but do not touch the intensity afterwards, right? Even though you might not be sensing it, the body's still sensing it. No need to keep cranking it up because you might actually cause muscular spasms and actually give yourself pain afterwards. So that's my rant on combining the two. But when it comes to heat, it's increasing what we call vasodilation. So opening up all those blood flow, bringing nutrition to the area, right? So if we increase blood flow, we're getting an increase in oxygen, we're getting increased white blood cells, we're getting all of this good nutrient that we need to help heal swarming to the area. But at the same time, we're also increasing the blood flow, taking all away the waste products, the garbage that's there from the body trying to heal. You're actually getting that pulled away. So that is awesome for pain relief, but also for healing overall. But then we're also looking at how do the muscles respond to that heat, and we can actually get the muscles calming down. We can see a decrease in the muscular spasm. And if there's pain associated with that muscle spasm and you've cured the muscle spasm, well then great, you're just feeling good afterwards. There are also some studies showing that heat overall produces those relaxing chemicals. So when we're in that stressful situation and we've got high levels of cortisol, it's actually shown that heat can decrease those and reproduce some relaxing chemicals, which is why sometimes after putting that heat pack on, you're feeling a little sleepy. There's a scientific reason behind that. So
Cool. Well, I think, there's a lot of people that will say, well, what is he going to do? It's just a temporary thing. It's, you put it on, it feels good, but then I go back to, having the pain again. And I think as a practitioner, we kind of would echo that that's what happens with medication as well. Somebody takes the Tylenol, you're also just changing the perception of pain or, for again, a short period of time too. So it's really maybe not solving the problem. But if it can, maybe a person is taking 2 Tylenol and instead of doing that, they have a heat pack and maybe 1 Tylenol. Again, it really can change everything, like you say, from sleep to mood to, then what about operating motor vehicles, right? Like people getting into, taking Percocet and some of the heavy narcotics and stuff, and so definitely there's impacts on safety and awareness and even productivity at work, so I think these are good things to consider, albeit maybe short term, and then that's where maybe getting moving and therapy and stuff come in, like you mentioned. Anything else you want to add about heat? I'd like to ask you about ice next.
yeah, no, I'm gonna hold my mic now. Karina said it's a little hard to hear me, so I'm gonna pull it down. Hopefully that's a little bit better there.
Can you hear me okay?
Oh yeah, I can hear you great.
Okay.
I was trying to use a speaker because there are still people treating in the clinic, so I didn't want to be blasting the noise in here. But yeah, no, with heat, I guess my only thing, like I said, is those situations where I try to tell clients try not to lay on top of heat. Obviously, we don't want to burn ourselves or get anything too hot. Or if those are those situations, again, like I said, if you feel like you're going to fall asleep, maybe set a timer if your heat doesn't have an automatic shut off, because like I said, you don't want to be sleeping on anything for too long. And the last thing you want is to wake up the next morning with some kind of burn, right? For in those worst case scenarios.
Crazy. Cool. Well, thank you for that summary. I do see there was a question popped in. I just made it show up on our screen here, and it's from Karina as well. And it's asking, is alternating heat and cold helpful, or is that a myth? Do you want to answer that one now, or do you want to do that after you talk about ice?
I can talk about that now. That's totally fine.
Perfect. Okay.
So those good old contrast baths that everybody loves. I find them super helpful. I don't personally, I don't use them too often for many other limbs. I use them a lot for lower limbs with the heat and ice. They create what we call like a muscle pump idea of we're doing that vasodilation and vasoconstriction, which kind of helps push everything out of the way. So I would find them super helpful for more for getting inflammation and swelling out, versus for pain. Typically, when I'm telling clients about heat and ice, I usually say pre-event stuff, we're using heat, and then post-event, we're using ice. It's not too often, minus those really swollen or hurting ankles and feet, that I use heat and ice otherwise. I don't know what you do either.
Yeah, no, same idea. I love it for the getting the lymphatic system, that whole neuro kind of vascular response to help change swelling, static or chronic static swelling, fluid bogged up, especially like you say, maybe it's 72 hours post. And one of the other reasons I really love contrasting ice and heat is it's not really heating anything because it's not on there long enough, and it's not really icing anything because it's not on there long enough to get to the depth of the tissue issue. Usually we need 15 to 20 minutes with both modalities, one and then the other, or just one. And so to go, like, often prescriptions for contrasting is like, 2 minutes or something each, or 5 minutes each, which really, as you know, doesn't get us anything. But when we get that kind of muscle pump kind of idea going on, it does get us some fluid, like movement of fluid. But the other thing I find is it gets people starting to heat, where if I've had somebody like 3 or 4 days straight icing because they just sprained their ankle or they got a big Charlie horse, then all of a sudden they've just kind of gone from icing to heating, and now they swell and they get sometimes a negative response from the first heat application. So I love it for that transitional phase as well. Anyways, what you asked, right? I was like,
Yeah, no, I like that.
my 2 bits. So with ice itself, we often think of ice for inflammation, like reducing inflammation and swelling, that kind of stuff. But today's topic is on pain management. And so, in the clinic, we'll get people, "Ooh, I hate ice," or, "Oh my God," so what do you do in that case? If somebody comes in and you're just looking to change pain, it doesn't have to do anything with inflammation. Do you prescribe ice?
Honestly, when it's just pain, it's not too often that I do prescribe ice. Typically because people find heat to be a little bit nicer, right? But it does. I mean, the physiology is there as well with ice. I mean, you're decreasing blood flow, you're decreasing that inflammation, which is great for those acute stages, like you said, like a day one ankle sprain. Absolutely, throw some ice on there from the early stages. It is also going to decrease that pain and swelling. We have what we call our pain spasm cycle, where we just kind of go in this constant cycle of things hurt, so the muscle spasms as a response, which hurts, so the muscle spasm. And sometimes ice can really help to get us out of that cycle. It can also slow down those nerve signals, so we're not really feeling the pain. As soon as you put ice on, everybody knows they kind of go through. I always warn my clients, you're going to go through these stages of, it's going to be cold, and then it's going to sting, and then it's going to burn, and then it's going to ache, and then it's going to go numb, right? And the numbness is great. But I am just careful when I'm giving that, because just because you can't sense the pain doesn't mean it's completely gone. So sometimes people put the ice on, they don't necessarily feel the pain, and then possibly push it a little bit more than they should. Yeah. But more often than not, I think when someone's in pain, or specifically with some of the chronic pain clients, I find heat is just a little bit more comfortable. So I end up prescribing that a little bit more often than I would with ice.
Okay. I know that, over the years, I'll get neurologists that have often, you're working with people that have like a lumbar disc, issue, or they've had surgery or something. And again, I think there's at least 2 instances where the surgeons have said to the client, just do whichever one feels better. And my clients often get confused by that. They're like, well, what does that mean? That seems like so silly. But I think the reality is that we're just trying to play on the gate mechanism to find something that feels good to break the pain spasm cycle, and override those pain messages that are coming on those slower conducting kind of neurons. And so, I think that's another kind of neat thing that, people are like, well, just tell me what to do. It's like, well, it's kind of like buying running shoes. It's like, well, just whichever ones feel good. It's like, well, it is really, really important that, yeah, that we don't force ice on somebody. If it's a chronic state of pain management, there's the odd person that loves it. And they're like, they come in and they're just like, I don't know, I just feels better. I love ice. I want to ice it, or they live in a hot climate. So, you know, I think to answer that question, it isn't about the physiology of the blood flow at that point so much as really just overriding the pain and what's resonating with you in that case. Cool.
Yeah.
Awesome. I'm just looking at, Brynna, like, what do you do in the case that, you know, I mean, obviously a client comes in and everybody's so different. How do you navigate? Like, do they heat and ice? And like, what's your strategy there?
I don't know. I think I kind of said it earlier. Like my job is to educate people as much as possible. So I typically, my clients know within that first assessment, I think I apologize like 5 or 6 times because I give a lot of information in that first appointment, which I mean, at the end of the day, it feels like it's my job to give people information, but specifically when we come to these things like pain management, I give them the information on heat, I give them the information on ice. I typically send them a quite a long email afterwards as well with all of that information. But I try to give people as much information as I can, and I kind of let them play with that a little bit and figure out themselves, right, what feels a little bit better. Usually I have a recommendation of kind of that gold standard of which I think in their case is going to help more, and I usually say try that first. But like you said, every so often we have someone come in where I think that in their situation heat should probably help more, and sometimes they come in the next week and they're like, actually ice feels great. I'm like, cool. Like whatever it is, like you said, to keep them moving and that work-life play, whatever it takes, right? I'll jump on board with it. I'll help support them with that too. But I try to give them as much information as I can without obviously absolutely doing way too much. But I kind of give them the information and let them pick themselves, right? Which is kind of a weird way of not answering that question, but that's just kind of my thing at the end of the day is I'll give them the information and then whatever works best. One of our profs in University of Winnipeg used to always say there are no cookie cutter treatments, right? There's the same thing with pain. There's no cookie cutter. There's no, you fall into this column. This is what you do. Every person's going to be different. So give them the information and whatever works is whatever works.
Okay. Well, I know the topics seem really simple today, TENS, heat and ice, but you know, it's so common. Like I can't overemphasize how many times in a day people are confused by it. Or their friend will have a TENS machine at home or a Dr. Hose and they don't know if they should or shouldn't. And, you know, is it going to hurt them? And I mean, the application is easy. You know, it doesn't really have a negative impact as long as the person's reading, you know, is there a neurological component? Is there a pacemaker? Is there maybe a, you know, epilepsy that needs to be looked at prior to, you know, to using it, or is it in certain areas depending? So, you know, definitely consulting with a practitioner is, you know, getting in touch with someone you trust to help you navigate that. And Brynna, it sounds like you're saying it's individualized, like everybody has their own, you know, kind of thing, depending on what is actually the underlying cause of this pain, obviously. So, you know, I think recommending, you know, that people do get to the root cause of their problem is number one. But in the meantime, some pain, you know, is known. Like, you know, it's an osteoarthritis, or you know that it's a blown disc that you have to self-manage until you see the surgeon or something. And so, you know, there's some stuff that we literally are just in a holding pattern. And so to take care of yourself, and I think reaching out. Is there anything else you'd like to add before we say goodbye?
Don't think so.
Okay. Well, that was really, really helpful. And for those of you that haven't met Brynna before, Brynna, I don't remember. I don't think you said that Brynna works at the Red Deer College location. So it's in the collegiate sports medicine grid your campus location. And we have a centralized number. So if you are looking for her, the 403-352-7979 number, or just go to our website and she'll be on there as well. And we'll maybe just put a little link to our website at the end of this. It is in our information in our Instagram page as well. So Brynna, thank you for joining me today.
Yeah, thanks for having me.
Yeah, you're welcome. Bye-bye. I got to figure out how to hang up now. Okay.